Okay, let's unpack this. Imagine having a roadmap that quickly gets you well informed on a really complex medical topic, turning dense info into something clear, actionable.
Yeah.
That's our mission today. We're taking a deep dive into the, well, intricate and often challenging world of viral hepatitis.
Yeah.
You've given us some comprehensive material on its pharmacology, and our goal here is to really help you master this information.
Right.
So you understand not just the what, but the why and how.
Yeah.
Almost like becoming an elite professional in this field.
And what's truly fascinating here is how we can sort of connect all the dots. From, the microscopic life cycles of these viruses, their profound impact on the liver,
Yeah.
all the way to the, frankly, revolutionary advancements in treatment and their global health implications. We're really going to try and make sure you grasp the nuances, the breakthroughs, and the challenges that still remain in this critical area.
So, to start us off then, what exactly is hepatitis at its core? And why do we talk about these different types? The term itself feels a bit broad, but I know the distinctions are absolutely crucial.
That's a perfect place to begin, yeah. At its most basic level, hepatitis just means inflammation and necrosis. That's tissue death of the liver. Simple as that.
Okay.
But the reason we talk about different types is because the cause, and therefore how it progresses and how we treat it, varies dramatically depending on which specific virus is involved. We basically group them based on how they're transmitted and whether they tend to lead to chronic long-term infection.
Got it. So transmission and chronicity are the keys.
Exactly. So on one side, you have hepatitis A, HAV, and hepatitis E, HEV. These are mainly transmitted through what we call the fecal-oral route.
Right. Contaminated food or water.
Precisely. Think hygiene-related transmission. Now, the good news here is that for most people, the illness these cause is self-limiting.
Meaning the body clears it on its own.
Yeah, usually the immune system handles it without specific antiviral drugs. Recovery is the norm. However, and this is a serious point, a small percentage, maybe 1 to 2%, can develop something called fulminant hepatic failure.
That's so bad.
It is. It's a rapid, severe liver failure, life-threatening. So even though HAV and HEV are typically self-resolving, there's still that small but very high-stakes risk.
Okay, so A and E. Mostly acute, self-limiting, but with that rare, scary complication. That seems like a major difference from the other types then.
A huge difference, precisely. On the other side, we have hepatitis B, HBV, hepatitis C, HCV, and hepatitis D, HDV. These are fundamentally different. Their main transmission route is parenteral.
Meaning bloodborne.
Exactly, bloodborne. So exposure to infected blood or bodily fluids. Think shared needles, maybe unsafe medical procedures, or even mother-to-child transmission during birth. And unlike A and E, these viruses can and often do progress to chronic infection.
And that's where the long-term danger lies.
That's exactly it. It's this chronic state that carries the severe long-term risks. Cirrhosis, that's irreversible scarring liver failure, where the liver just can't do its job anymore. And hepatocellular carcinoma, HCC, which is primary liver cancer. This is really where viral hepatitis becomes a profoundly serious, potentially lifelong health challenge.
Okay, so B, C, and D are the chronic ones.
Generally speaking, yes. Now, within these bloodborne viruses, there are two absolutely crucial distinctions. Getting these is like an aha moment if you want to master this field.
Okay, I'm ready.
First, HBV is vaccine preventable. We have excellent vaccines, a major public health win.
Great.
But our current treatments for HBV are not completely curative. They suppress the virus, manage the disease, but they don't fully eliminate it.
Why not?
Well, it's because the virus sets up this persistent little structure called cccDNA, like a mini chromosome, inside the liver cells. Our drugs just can't get rid of that right now.
Ah, okay. So preventable, but hard to cure. What's the contrast with HCV?
So for HCV, here's the stark contrast. There is currently no vaccine available. Prevention relies on other measures like screening blood, safe practices.
Okay, no vaccine.
But, and this is the really revolutionary part, HCV can be cured with effective treatments. Modern therapies are incredibly successful.
Wow. So completely opposite.
Almost. One's vaccine preventable, but tough to cure. The other has no vaccine, but we can largely cure it with pills. It's a massive difference in approach and outcome.
That really highlights the specific challenges for each virus. What about hepatitis D? You mentioned HDV earlier. It sounds like an oddball.
It really is unique. HDV, or the hepatitis D virus, is what we call a defective virus. Think of it like a parasite that needs another parasite to survive.
Okay.
It absolutely requires the presence of HBV to replicate and actually cause an infection. It simply cannot propagate on its own.
So you only get Hep D if you already have Hep B.
Exactly. HCV infection only ever happens in people already infected with HBV. It's a co-infection. And the really unfortunate consequence is that people with both HBV and HDV face a significantly greater risk for severe outcomes, like faster progression to cirrhosis and liver cancer, compared to those with just HBV alone.
That's rough. Is it common?
Thankfully, no. It's relatively less common. It affects maybe about 5% of HBV-infected individuals globally. Treating it is also tough. Options are limited. Pegylated interferon alpha, PEGIENA, is one, but it only works in about 20–35% of patients.
Not great odds.
Not great at all. More recently, though, there's bulevirtide. It's an agent approved in Europe, and it offers some new hope. It works by blocking the virus from entering liver cells.
Okay, so that covers the different types. And it really highlights this divide in how they behave and how we have to approach them.
Yeah.
This seems to lead directly into understanding liver disease severity itself. It's not just if you have hepatitis, but how bad the liver damage is, right? That changes everything for treatment.
Absolutely. You've hit on a critical point. When we're treating chronic viral hepatitis, so primarily B and C, assessing the stage and severity of a liver disease isn't just important, it's the absolute roadmap. It dictates everything.
I like that.
Yeah, it guides monitoring, treatment choices, duration, everything. The liver is incredibly resilient, but that constant damage from chronic HBV or HCV can lead to really serious conditions over time. The first major milestone, and it's a concerning one, is cirrhosis.
Which is scarring, right? But serious scarring.
Exactly. Not just a little bit. It's widespread, irreversible scarring that messes up the liver's normal structure and function. Once a patient hits cirrhosis, they absolutely need more rigorous monitoring for complications.
Like what kind of complications?
Things like esophageal varices. These are enlarged, fragile veins in the esophagus that can rupture and bleed dangerously. And of course, a much higher risk of hepatocellular carcinoma, liver cancer. The whole treatment approach changes significantly for people with cirrhosis, especially if it becomes decompensated compared to those who just have chronic hepatitis without major scarring yet. We can diagnose cirrhosis in a few ways. A liver biopsy, looking at the tissue itself, imaging like MRI or ultrasound, or certain lab tests that point toward significant damage.
So cirrhosis is a big turning point. Monitoring becomes crucial. What's the next stage if it gets worse?
That would be decompensated cirrhosis. This is often called end-stage liver disease. And this isn't really a lab diagnosis initially. It's more clinical. It's based on the obvious presence of severe symptoms and life-threatening complications.
Like the variceal bleeding you mentioned.
Exactly. Variceal hemorrhage, severe bleeding. Also ascites, which is that uncomfortable buildup of fluid in the belly. Jaundice, the yellowing of skin and eyes because the liver can't process bilirubin. Or hepatic encephalopathy, brain dysfunction, because the liver isn't clearing toxins from the blood.
That sounds incredibly serious.
It is. Decompensated cirrhosis carries a very high mortality risk. The median survival without intervention, like a transplant, is maybe only about 2 years. It's grim.
Wow.
So for these individuals, the focus shifts immediately to life-saving measures, and they absolutely should be evaluated for a liver transplant.
That really paints a stark picture of the progression. But I know doctors use specific scores to quantify this, right? It's not just observing these symptoms.
You're absolutely right. For professionals managing these patients, scoring systems are key metrics. They provide objective measures. The main one for figuring out urgency for liver transplantation is the Model for End-Stage Liver Disease Score, or MELD score.
MELD. Okay.
It's calculated using 3 common lab values. Bilirubin, which reflects liver processing. INR, the blood clotting time, which indicates liver function. And serum creatinine, which checks kidney function, because kidneys often suffer in advanced liver disease.
Right. So bilirubin, INR, creatinine.
Yep. And basically, a higher MELD score means higher mortality risk, and therefore a more urgent need for a transplant.
Makes sense. And there's another one, Child-Pugh.
Yes, the Child-Pugh score. This one is used more to categorize the severity of the cirrhosis itself. It includes bilirubin and INR, like MELD, but also adds albumin levels, another liver function marker, and crucially, the presence or absence of ascites and encephalopathy.
So it includes those clinical signs too.
Exactly. It puts patients into categories. Category A is mild impairment, Category B is moderate, and Category C is severe hepatic impairment. And critically, people with Child-Pugh scores B and C are considered to have decompensated cirrhosis. So being familiar with both MILODI and Child-Pugh and understanding that difference between compensated and decompensated cirrhosis is absolutely fundamental for anyone wanting to master the pharmacology of HBV and HCV treatment. It dictates who gets what therapy and when.
This level of detail, getting into MELD and Child-Pugh, it really drives home how precise and critical that diagnostic assessment is before even starting treatment. It's clearly not one size fits all. So, okay, let's break down the major viruses now. Starting with hepatitis B, given its unique global challenges and that difficulty in achieving a complete cure.
Right. Let's transition to HBV. It has just an immense global impact and presents these unique challenges that keep driving research. The numbers are really quite staggering. It's estimated around 2 billion people worldwide have been infected at some point.
2 billion, wow.
Yeah. And about 240 million are living with chronic disease. This was from a WHO report back in 2015. This makes HBV the leading cause of liver-related deaths globally. We're talking around 686,000 deaths every year.
That's huge. Where is it most common?
It's most prevalent or endemic in places like sub-Saharan Africa and parts of Asia like China, the WHO Western Pacific region. And in these high endemicity areas, a key factor is how it's acquired. It's primarily perinatal transmission.
From mother to child at birth.
Exactly. And this is crucial for understanding why it becomes chronic so often. If you're infected at birth, there's a 90% risk of developing chronic disease.
90%.
Versus maybe only 5% if you get infected as an adult. Big difference. And for those with chronic HBV, the lifetime risk of developing serious complications, cirrhosis, liver failure, HCC, is somewhere between 15 and 40%.
So the need for effective long-term management is clear, especially since you said a complete cure is still out of reach.
Precisely. That's the ongoing challenge.
It makes sense that genetics would play a role in a virus this widespread. How does the genetic diversity of HBV impact things? Does it affect treatment?
Oh, it's a significant factor. Really highlights the complexity. HBV shows considerable genetic variation. We've identified at least 10 HBV genotypes, labeled A through J, plus over 35 subtypes.
10 genotypes.
Yeah, and they have distinct geographical distributions. Like, genotype A is common in North America and Africa. B and C dominate in East Asia, often linked to that perinatal transmission. D in Southern Europe and India, E in Sub-Saharan Africa, and so on. And this isn't just, academic classification. It actually impacts the clinical picture and, importantly, the response to antiviral therapy.
Oh, so?
Well, for example, the chance of achieving what's called HBag loss, or seroconversion, that's a marker of the immune system getting some control, is generally better with genotypes A and D compared to B and C. So knowing the genotype is one piece of the puzzle when making treatment decisions. It's crucial for that deeper professional level understanding.
Incredible detail on the genotypes. It really underscores the complexity. Can you walk us through the HBV genome itself and its life cycle? Understanding how it works molecularly must be key to fighting it, and especially understanding why that complete cure is so hard.
It absolutely is. Understanding the viral blueprint is fundamental. HBV is a small, enveloped virus, and its genetic material is relaxed circular DNA.
Relaxed circular.
Yeah, meaning it's DNA but not fully double-stranded. It has a complete minus strand and an incomplete plus strand. Inside, the nucleocapsid contains the core antigen, HBCA, the viral polymerase enzyme, and that DNA. This core is wrapped in an outer lipoprotein envelope containing the HBV surface antigen, HBsAg. That's often what the immune system sees, or what vaccines target. The genome itself is remarkably compact, with just 4 overlapping regions encoding all its proteins. Very efficient.
Okay, so how does it replicate? What's the life cycle?
Let's unpack it. It's intricate. 1. Attachment and entry. First, the virus latches onto specific receptors on the surface of a liver cell, a hepatocyte. Think key in a lock. This triggers the cell to engulf the virus endocytosis, bringing the nucleocapsid inside.
Okay, it gets in.
To the nucleus and cccDNA formation. Once inside, the nucleocapsid travels to the cell's nucleus. Here, that partial DNA strand is repaired, forming a complete, superstable, double-stranded circle called covalently closed circular DNA, or cccDNA. Now, this is the critical point. cccDNA is not eliminated by any current treatments.
Wow, there it is, the persistent part.
Exactly. This is why a complete cure isn't possible yet. It acts like a stable, long-lasting template in the nucleus, a hidden blueprint that can always be reactivated even after years of the virus being suppressed.
Like a viral reservoir.
Precisely.
Mhm.
3. Making viral stuff. This cccDNA then serves as the master template. The cell uses it to make various viral RNAs. These RNAs go out into the cytoplasm to be translated into viral proteins, like the envelope protein, HBsA. Interestingly, the virus makes a huge excess of these envelope proteins, released as subviral particles, basically empty shells.
Why?
It's thought they act like decoys, flooding the immune system with antigen, contributing to immune tolerance and exhaustion, making it harder for the body to fight back effectively.
Clever in a sinister way.
Very. 4. Replication and assembly. A specific larger RNA, the pregenomic RNA, is used to form new viral core proteins. Inside these new cores, the pregenomic RNA is then reverse transcribed back into viral DNA.
Wait, reverse transcribe, isn't HBV a DNA virus?
It is. But it uses its own polymerase enzyme, which uniquely also functions as a reverse transcriptase. It copies RNA back to DNA. It's a key feature. 5. Recycle or release. Finally, these new nucleocapsids have two choices. They can go back to the nucleus to make more cccDNA, reinforcing that reservoir.
Perpetuating the cycle.
Right. Or they can assemble with the envelope protein and get released from the cell as new infectious virus particles ready to infect other cells. This whole intricate self-perpetuating cycle, especially that persistent cccDNA, is what makes HBV such a challenge. It's a constant battle of suppression, not eradication.
That's a truly complex and persistent life cycle. That cccDNA explanation really clarifies why complete cure is so elusive. So knowing this, what are the actual drug targets and the overall treatment approach, given we can't just eliminate it?
Right. Given this dynamic cycle, HBV infection isn't static. People can move through different phases over their lifetime. Treatment isn't always immediate. It's typically reserved for people with high levels of circulating HBV DNA, ongoing liver inflammation indicated by elevated ALT levels, those who've already developed cirrhosis, or, importantly, to prevent reactivation in patients getting immunosuppressive drugs, like chemotherapy.
What about kids?
Good question. While the approach is similar, most kids have normal ALT levels and often don't need immediate treatment. Their immune system is still maturing. And as we've stressed, current therapies cannot achieve a complete cure because they don't tackle that cccDNA. A small fraction, maybe 10% of patients, achieve what we call a functional cure.
Functional cure, meaning
undetectable HBV DNA in the blood, and they develop antibodies to the surface antigen seroconversion from HBsAg to anti-HBs. It's like they resolved an acute infection naturally.
but the cccDNA is still there.
Still there, exactly. So even with a functional cure, there's always that potential for reactivation, especially if the immune system weakens or therapy stops.
Okay, so what are the main treatment options we do have?
Two main categories. First, pegylated interferon alpha, PEGFN. It gives broad antiviral and immune-boosting effects. It's a finite treatment, usually about a year. Second, and more common now, are the nucleoside and nucleotide analogs. Drugs like entecavir, tenofovir.
How do they work?
They primarily inhibit the HBV polymerase, that replication enzyme. They basically jam the works. But unlike interferon, these often require lifelong treatment to keep the virus suppressed. Among those analogs, entecavir and tenofovir, specifically its two forms, PDF and TF, are the preferred first-line therapies because they're very potent, generally well-tolerated, and critically have a low potential for the virus developing drug resistance. That's huge for long-term therapy. Choosing between them involves considering liver disease severity, patient adherence, prior treatments, side effects, other health issues, etc. So since complete cure isn't feasible and functional cure is rare, the goals are clear. Suppress the HBV DNA as much as possible, encourage HBsAg seroconversion as applicable, slow down liver disease progression, reduce the risk of complications like HCC, and ultimately prolong survival. It's about long-term management.
That makes perfect sense. Manage, suppress, prevent complications. But if it's often lifelong treatment, what happens when the virus develops resistance? That sounds like a major potential problem.
It absolutely is. And understanding the viral dynamics is key here. HBV replicates incredibly fast, and its polymerase enzyme lacks a proofreading function.
Like a sloppy copier.
Exactly. It makes lots of mistakes, leading to constant mutations. When you apply the pressure of an antiviral drug, any mutations that happen to confer resistance get selected for and start to dominate. It's evolution in action, unfortunately. And the resistance rates vary hugely between drugs.
Okay.
Lamivudine, for example, has the lowest genetic barrier to resistance. It's easy for the virus to beat it. After just 4 years of using only lamivudine, a shocking 71% of patients develop resistance.
71%? Wow.
Yeah, makes the drug useless. Telivudine sees about 22% resistance after 2 years, adefovir about 29% after 5 years. But in contrast, tenofovir disoproxyl fumarate, TDF, has very uncommon resistance. And with the newer form, tenofovir alafenamide fumarate, TAF, resistance has basically not been observed through 4 years of treatment.
That's a massive difference.
Yeah, huge. Entecavir is also very good. Less than 1% resistance after 5 years in treatment-naive people. Though if someone already has resistance from, say, prior lamivudine use, entecavir resistance can become more common. The consequences of resistance are serious. Treatment failure, rapid viral rebound, and that can push patients towards hepatic decompensation, severe liver failure. For these reasons, guidelines strongly say do not use lamivudine, adefovir, or telbivudine as monotherapy. Patients still on them need constant monitoring and strict adherence counseling.
So resistance is clearly a major factor driving the preference for tenofovir and entecavir. But what about patients who already have significant liver damage, like cirrhosis? How do these treatments work for them? Is it different?
It is different, and another critical area, keeping HBV DNA suppressed long-term is vital because it not only stops further damage, but can actually help reverse some existing liver scarring. But the choice of therapy depends heavily on how damaged the liver already is.
Okay.
While PEG's FNI might be used in compensated cirrhosis,
Right.
where the liver is scarred but functioning okay, it's absolutely contraindicated, forbidden in decompensated cirrhosis,
Why?
because it can actually make things worse, precipitate clinical deterioration, and increase the risk of serious bacterial infections.
Right. So what do you use for decompensated cirrhosis?
The nucleoside and nucleotide analogs are the treatment of choice. They've been shown to dramatically improve liver function and boost 5-year survival rates in these very sick patients from maybe 14-35% up to 55-86%. Sometimes they can even prevent the need for a liver transplant.
That's a huge improvement. Which analogs are preferred?
Again, entecavir and tenofovir, TDF or TAF, are the preferred agents. Both need careful dose adjustments if the patient has kidney problems, as they're cleared by the kidneys. And there are specific risks to watch for. TDF has links to nephrotoxicity, kidney damage, while entecavir carries a risk of lactic acidosis in this group. So careful monitoring is essential. Sometimes combinations of analogs might be needed, especially if there's pre-existing resistance, and it's a general safety point. All these nucleotide analogs carry a black box warning about the risk of lactic acidosis, which can be more pronounced in advanced liver disease.
It really sounds like a careful balancing act for clinicians, especially with advanced disease, weighing the benefits against these potential risks. Let's really get into the specifics of the drugs now. Tell us more about interferons first, then each of the key analogs. What are the absolute must-knows for each?
Okay, let's do a deep dive on each agent. First, interferons, specifically pegylated interferon alpha, PEGSMNE. These are powerful signaling molecules, cytokines, that our own cells make naturally to fight viruses. They basically put cells into an antiviral state.
And pegylated just makes it last longer.
Exactly. Attaching it to polyethylene glycol, PEG, slows absorption, reduces clearance, lets you dose it just once a week via injection. PEG-FNI is a preferred first-line agent for HBV in certain patient profiles. Mechanistically, it triggers pathways that lead to antiviral proteins being made, inhibits viral protein synthesis, and also stimulates immune cells. But the side effects are a big factor. Many people get an acute flu-like syndrome fever, chills, aches right after injection. Tolerance develops, but it's unpleasant.
What about more serious issues?
Dose-limiting toxicities can include depression, myelosuppression, low blood counts, neurotoxicity, confusion, behavioral changes, debilitating fatigue, and autoimmune disorders like thyroid problems. And critically, as we said, it's contraindicated in advanced liver disease.
But it has some advantages.
Yes, the treatment course is finite, 48 to 52 weeks, and it can lead to higher rates of HB ag loss and even HBs ag loss compared to the analogs, which is a plus. But not everyone responds well.
Okay, that's interferon. Powerful, finite, but with significant side effects and contraindications. Now, let's move to the nucleoside analogs. Start with entecavir. Why is it preferred?
Entecavir. It's a guanosine analog, so it mimics one of the building blocks of DNA. It gets activated inside the cell and then powerfully inhibits all 3 key functions of the HBV polymerase enzyme, basically jamming the virus's replication machinery on multiple steps. It's preferred because it's highly potent, durable, and has that very low risk of resistance developing, especially in treatment-naive patients.
Any specific considerations?
Yes, the HIV co-infection issue is important. Entecavir has some anti-HIV activity, so if someone has HIV that isn't fully treated, using entecavir alone for HBV could lead to HIV drug resistance. It must be part of a fully suppressive HIV regimen in co-infected patients. Also, administration, taken on an empty stomach, food significantly cuts its absorption.
Side effect.
Generally well tolerated. The biggest concern is the potential for severe hepatitis flares if you suddenly stop the drug. So close monitoring after discontinuation is crucial. It's also approved for kids aged 2 and up.
Got it. Potent, low resistance, but watch for flares on stopping, and the HIV co-infection interaction. Now, tenofovir, you mentioned 2 forms, TDF and TAF. What's the story there?
Right, tenofovir is the other cornerstone preferred agent. And the 2 prodrug formulations, tenofovir disoproxil fumarate, TDF, and tenofovir alafenamide fumarate, TAF, represent an important evolution. TDF is the older form. It's an acyclic nucleoside phosphonate prodrug. It's converted to the active form, tenofovir diphosphate, inhibits the polymerase. Like entecavir, it has a high genetic barrier to resistance, which is excellent.
But drawbacks.
Yes. Its main challenge lies in potential long-term side effects, specifically kidney toxicity, nephrotoxicity, and decreased bone mineral density, leading to potentially weaker bones over time. It needs dose adjustments for kidney problems.
Okay, so TDF is effective, high barrier, but potential kidney and bone issues. How does TF improve on that?
TAF is the newer prodrug. The key difference is how it delivers tenofovir to the cells. TAF is more stable in the blood and gets taken up much more efficiently into the cells, including the liver cells where HBV replicates.
So more targeted delivery.
Exactly. This means you can use a much lower dose of TAF, 25 milligrams versus 300 milligrams for TDF, to get the same or even higher levels of the active drug inside the target cells. And because much less drug circulates in the bloodstream and gets filtered by the kidneys, TAF results in significantly fewer adverse effects on bone density and kidney function compared to TDF.
That sounds like a major improvement.
It is. It makes TAF a safer long-term option, especially for patients with baseline kidney issues or bone health concerns. So while both TDF and TAF are preferred agents due to potency and resistance profile, TF often has the edge because of its improved safety, especially regarding kidney and bone health.
That's a really clear explanation of the TDF versus TIA evolution, TF offering key safety advantages. So what about those other agents you mentioned earlier, adefovir, lamivudine, telbivudine? Are they ever used now? What were their main issues again?
Yeah, they're definitely considered alternative agents now, and their use has really dropped off because entecavir and tenofovir are just superior in key ways. They are generally not recommended as monotherapy anymore. Let's recap why. First, adefovir, older nucleotide analog. It's big problem. Resistance emerges in nearly 30% of patients after 5 years. That increases the risk of liver disease worsening. Plus, it has that risk of kidney toxicity.
Okay, resistance and kidney issues for adefovir. Lamivudine.
Lamivudine, one of the earliest oral HBV drugs. Its Achilles heel is the extremely high resistance rate. Remember, 71% after 5 years.
Yeah, that's unusable long term.
Pretty much. It just becomes ineffective too quickly, risking viral rebound and liver damage.
Hey,
So despite being generally well tolerated, that resistance profile makes it a poor choice now.
And telbivudine.
Telbivudine, another nucleoside analog. It looked promising initially, but again, resistance pops up in about 22% after just 2 years. Like lamivudine, that high resistance rate means it's not a preferred agent, and notably, the U.S. manufacturer actually stopped making it.
So they're really legacy drugs now.
Largely, yes. They really underscore why having drugs with a high genetic barrier to resistance, like entecavir and tenofovir, is so crucial for managing a chronic viral infection like HBV.
That's a very thorough breakdown of the current HBV toolkit. It really paints a picture of managing a persistent virus, constantly balancing efficacy against resistance and side effects, all while that cccDNA challenge looms.
So, what is on the horizon? Any hope for tackling that cccDNA directly?
That is the million-dollar question, isn't it? Because yes, the persistence of cccDNA is the fundamental hurdle. Current drugs achieve that functional cure in only a minority, but not a complete sterilizing cure because the cccDNA remains, always holding that potential for reactivation. So yes, new agents are desperately needed.
What kind of approaches are being explored? Research is intense, focusing on multiple novel antiviral targets and ways to boost the immune system. The targets reflect a much deeper understanding of the HBV life cycle now, we're seeing. Entry inhibitors, drugs to literally block the virus from getting into liver cells. Bulevirtide, approved for HCV, is one example. cccDNA disruptors. This is the holy grail, really. Agents designed to directly target, destabilize, silence, or even eliminate that cccDNA reservoir. That would be truly transformative. Capsid assembly inhibitors. These mess with the formation of the viral core, preventing proper packaging of the genetic material. RNA interference compounds. These use small RNA molecules to specifically find and degrade the viral messenger RNA, shutting down protein production, like silencing the virus's instructions.
So attacking it from multiple new angles.
Exactly. Some specific agents further along in development include bulevirtide, the entry inhibitor, capsid inhibitors like J&J 6379 and ABI 80731, and RNA interference compounds like ARO-HBV. There's also REP 2139, which targets the release of those decoy HBsAg subviral particles, potentially reducing immune exhaustion. And beyond direct antivirals, there's a lot of work on immunomodulators, things like checkpoint inhibitors or agonists that stimulate specific immune pathways, like toll-like receptors or ERG-Y, to help the body's own defenses fight HBV more effectively.
So the future looks like combination therapy.
Very likely. The vision is probably using combinations of these new compounds, perhaps together with interferon or the current nucleoside-nucleotide analogs. A multi-pronged attack will likely be needed to achieve higher rates of functional cure, and maybe, just maybe, start tackling that cccDNA to get closer to a true cure.
That's a really deep dive into HBV, the sheer complexity of its life cycle, that persistent cccDNA, the challenges of resistance. It truly stands out. But now, let's pivot. Let's shift our focus to HCV, hepatitis C, where you said the treatment story has taken this incredibly different, incredibly hopeful turn.
Indeed. The HCV treatment landscape is, frankly, one of the biggest medical success stories of the last couple of decades. It's quite remarkable. Globally, though, it's still a huge issue. Around 71 million people live with chronic HCV. Highest rates are often seen in Africa and parts of Central and East Asia. And unlike HBV, where chronicity risk varies, with HCV, the majority of infected people, maybe 70%, develop chronic infection.
70%, wow.
Yeah. And without treatment, that chronic infection often progresses over decades to cirrhosis and then complications like decompensated liver disease or liver cancer. Sadly, there are still around 400,000 HCV-related deaths globally each year.
So clearly a major problem, but you mentioned this hopeful turn before we get to the cure part. What about HCV's genetic diversity? You hinted it was a problem for vaccines, unlike HBV.
Right. HCV exhibits really remarkable genetic diversity, much more so than HBV in some ways, both within a single person and between different people. This incredible variation is the major roadblock to developing a universal preventative vaccine. The virus just changes too much.
Yeah.
We've identified at least 6 main HCV genotypes with significant genetic differences, and then there are subtypes within those. And while how easily it spreads doesn't seem to differ by genotype, the rate of disease progression and, critically, the response to different treatments do differ significantly by genotype.
So genotype matters for treatment choice.
Absolutely. Genotype 1 used to be considered harder to treat, and it's the most common globally, followed by genotype 3. Knowing the genotype was essential for picking the right older therapies, and while less critical with newer drugs, it still plays a role.
So no vaccine because it's too diverse, but you mentioned a cure. Explain the HCV genome and life cycle. What makes this one curable when HBV isn't? That's the huge question.
This is the revolutionary difference. HCV's genome is positive sense, single-stranded RNA, not DNA. And crucially, its entire replication cycle happens within the cytoplasm of the liver cell. It never goes into the nucleus like HBV.
No nucleus involved.
Nope. And because of that, it does not establish latency. There's no persistent nuclear form like HBV's cccDNA, and that is why it is curable.
Ah, okay. No hidden reservoir.
Exactly. We can eliminate the replicating virus, and once it's gone, it's gone. The cure for HCV is formally defined as achieving a sustained virologic response, or SVR.
SVR. What does that mean specifically?
It means having no detectable HCV RNA in the blood 12 weeks after finishing treatment. If the virus hasn't come back by then, it's considered cured. And achieving SVR is huge. It dramatically decreases liver disease progression, reduces liver-related deaths, and even reduces deaths from all causes. It's a true cure with massive benefits.
Okay, so how does its life cycle work then, briefly? How does it replicate in the cytoplasm?
Sure. 1. Entry. Like HBV, it binds to receptors on the liver cell and gets taken inside via endocytosis. 2. Replication in the cytoplasm. Once inside, the viral RNA is released, no trip to the nucleus. This RNA is directly translated into one large polyprotein. Host and viral enzymes then chop this big protein into 10 individual functional proteins.
Okay.
3. The membranous web. These viral proteins, along with parts of the host cell, rearrange internal membranes to form this unique structure called the membranous web. Think of it as a protected viral replication factory inside the cytoplasm. 4. RNA replication. Inside this web, the key enzyme, NS5B RNA-dependent RNA polymerase, RDRP, makes copies of the viral RNA genome. 5. Assembly and release. New HCV RNAs are packaged into new virus particles, which then bud through internal membranes and are eventually released from the cell to infect others. So the whole process stays in the cytoplasm, and crucially, no persistent cccDNA is formed. That's the biological basis for why HCV is curable.
That's fascinating. The lack of that nuclear step makes all the difference. It makes the treatment revolution so much clearer. What were treatments like before these new drugs came along? You mentioned interferon again.
Yeah, for many years, HCV treatment was, frankly, brutal. It involved long courses, often 48 weeks, of weekly interferon alpha injections, usually combined with daily ribavirin pills.
Sounds rough.
It was. The SVR rates, the cure rates were often low, sometimes well below 50%, and the tolerability was terrible. Flu-like symptoms, extreme fatigue, depression, anemia meant people just couldn't complete the treatment because the side effects were so bad.
So low cure rates, awful side effects. What changed? What are these direct-acting antivirals?
Yeah.
This is where the revolution happened. Scientists developed several classes of drugs that directly target specific HCV proteins essential for its replication. These are the direct-acting antivirals, or DAAs. The advantages are just night and day compared to interferon. They're oral pills, no injections. They have far fewer side effects, generally very well tolerated. Treatment duration is much shorter, typically just 8 or 12 weeks. And the most amazing part, they achieve SVR rates of around 95% or even higher in most patients.
95% cure rate with pills in 8-12 weeks. That's unbelievable.
It truly is. Because of this, interferon is completely gone for HCV treatment. Ribavirin still has a small role, sometimes added to DAAs in difficult-to-treat cases like severe cirrhosis, just to boost those cure rates even higher. This revolution was possible because we gained such detailed knowledge of the HCV life cycle and protein structures, allowing targeted drug design.
What are the main targets for these DAAs?
There are 3 major classes targeting key viral proteins. 1. NS34A protease inhibitors. The NS3 protease is essential for cutting that large viral polyprotein into functional pieces. Inhibiting it stops the virus from building its replication machinery, prefer suffix usually. 2. NS5B polymerase inhibitors. This RDRP enzyme is crucial for copying the HCV RNA genome. Inhibitors can be nucleotide analogs like sofosbuvir that act as chain terminators, or non-nucleoside inhibitors that bind elsewhere on the enzyme, the Vuvir suffix usually. 3. NS5A inhibitors. NS5A is a protein vital for both RNA replication and assembling new virus particles. We don't fully know exactly how it works, but inhibiting it is incredibly effective, as for suffix usually.
So specific inhibitors for the protease, the polymerase, and this NS5A protein. It's amazing how targeted that is. But even with these incredibly effective drugs, what about resistance? HCV replicates so fast. Is resistance still a concern, like with HBV?
It is still a consideration, yes. HCV produces almost 1 trillion virus particles daily, and like HBV's polymerase, the HCV NS5B polymerase is error-prone. It lacks proofreading, so spontaneous mutations are constantly happening. This means that even before treatment, a person's HCV population can contain viruses with pre-existing resistance-associated substitutions, or RS. These RS can affect cure rates with certain DAAs.
Okay. Does it vary by drug class?
It does. The nucleotide NS5B polymerase inhibitors, like sofosbuvir, generally have a high genetic barrier to resistance. It takes multiple mutations for the virus to become significantly resistant.
That's good.
Yes, but the non-nucleoside NS5B inhibitors, the NS3 protease inhibitors, and the NS5A inhibitors generally have a lower genetic barrier. Sometimes just 1 or 2 amino acid changes can cause resistance and treatment failure, especially if one of these drugs were ever used alone, which they aren't.
Oh, so that's why combinations are key for HCV too.
Absolutely essential. Just like with HIV, modern HCV treatment always uses a combination of DAAs, often targeting different proteins, like a polymerase inhibitor plus an NS5A inhibitor. This maximizes viral suppression and provides coverage against pre-existing RS, preventing the emergence of new resistance during therapy. We're also learning that some RS, particularly against NS5A inhibitors, can persist for years after treatment failure, which complicates retreatment choices.
Okay, so combinations are crucial to overcome resistance. What about liver impairment? Does having cirrhosis affect the high cure rates with DAAs?
That's another important factor. While the vast majority of people, even with some liver damage, achieve SVR rates over 90%, patients with decompensated cirrhosis do tend to have slightly lower SVR rates.
But cure is still possible.
Oh yes, cure is still very possible and highly beneficial. Achieving SVR in decompensated patients can significantly improve their MELODY scores and even lead to fibrosis regression. However, it's important to realize that even after cure, they might still have significant long-term health issues related to their advanced liver disease. This really emphasizes the point that the optimal time to treat HCV is early before significant liver damage occurs. The risks of progressing to cirrhosis, HCC, needing a transplant, or dying are dramatically lower if you treat someone when they have minimal fibrosis versus waiting until they have advanced fibrosis or cirrhosis.
That makes total sense. Treat early, prevent the damage.
Exactly. The biggest challenge now isn't the drugs themselves, it's finding the millions of people who have HCV but don't know it yet, and getting them diagnosed and linked to care so they can be treated early. That's the major public health hurdle.
A crucial point. Okay, let's finally dive into the specifics of these revolutionary DAA drugs. Start us off with sofosbuvir. It seems to be a backbone of many regimens.
It absolutely is. Sofosbuvir is a foundational drug in modern HCV therapy. It's a nucleotide analog prodrug targeting the NS5B polymerase.
Prodrug means it needs activation.
Yes, it gets converted to its active triphosphate form inside the cell. Then it acts like a faulty building block, mimicking uridine triphosphate, that gets incorporated into the growing HCV RNA chain by the NS5B polymerase, but it stops the chain from extending further. It's a chain terminator. Key features. It has a high barrier to resistance, which is excellent. And because the NS5B polymerase active site is very similar across different HCV types, sofosbuvir is active against all HCV genotypes. Pangenotypic.
Pangenotypic, that's huge for simplifying treatment.
Massive. Its standard dose is 400 milligrams once daily. It's almost always used in combination with other DAAs, typically an NS5A inhibitor or sometimes an NS3 protease inhibitor. While generally very safe, the one major drug interaction to be extremely cautious about is with the heart rhythm drug amiodarone. Combining sofosbuvir-containing regimens with amiodarone has led to severe bradycardia, slow heart rate, and even cardiac arrest. If the combo is absolutely necessary, intensive inpatient cardiac monitoring is required initially.
Good to know. A cornerstone drug, pangenotypic, high resistance barrier, but watch out for that amiodarone interaction.
Okay, what about ribavirin? You said it's still used sometimes as an add-on.
Right. Ribavirin isn't a DAA. It's an older, broad-spectrum antiviral. It's a purine nucleoside analog. Its exact mechanism against HCV isn't fully pinned down, but it seems to interfere with viral RNA synthesis and might also tweak the immune response. Interestingly, resistance doesn't seem to be a clinical problem with ribavirin in HCV.
So why is it still used? Its main role now is as an adjunctive agent, added onto DA regimens in specific, harder-to-treat situations to help boost the SVR rates. This includes some patients with decompensated cirrhosis or those who have failed previous treatments. Dosing is weight-based, taken twice daily. Its big drawback is the side effect profile, primarily dose-related hemolytic anemia.
The red blood cell breakdown.
Exactly. It can cause significant fatigue and often requires dose reductions or even stopping the drug if hemoglobin drops too low. And the other huge issue is its black box warning for being teratogenic and embryotoxic. It can cause severe birth defects, so it's absolutely contraindicated during conception attempts for both men and women, and for 6 months after stopping treatment. Strict contraception is mandatory.
Wow, so a useful booster in specific cases, but with major side effects, especially anemia and the profound risk of birth defects. Okay, let's get to the main DAA combinations. Ledipasvir, always found with sofosbuvir, right? LDV-SOF.
Correct. The fixed-dose combinations really streamline treatment. Ledipasvir LDV is an NS5A inhibitor. It's only available co-formulated with sofosbuvir, SOF, in a single tablet, LDV-SOF. Ledipasvir works by inhibiting that crucial NS5A protein involved in replication and assembly. While highly effective, baseline NS5A resistance mutations, RASs, can slightly lower cure rates, especially in genotype 1A, and these RAS can linger, potentially impacting future treatment.
How is it used?
It's a once-daily pill, a key practical point. Its absorption depends on stomach pH. It needs an acidic environment, so acid-reducing medications like antacids, H2 blockers, and especially proton-pump inhibitors, PPIs, can interfere with its absorption and must be managed carefully, either avoided, dose-adjusted, or timed precisely relative to the LDVSOF dose.
Okay, pH matters for Letipasvir. Which genotypes is it for?
LDVSOF is FDA approved for HCV genotypes 1, 4, 5, and 6. It also has approval for use in decompensated cirrhosis, often with added ribavirin in that case. SVR rates are excellent, typically 96–99% for 12 weeks of treatment. Side effects are usually mild fatigue and headache are most common.
Got it. LDVSOF for specific genotypes 1, 4, 5, 6. Highly effective. Watch the stomach acid interactions. Now, Daclotasvir. Used with sofosbuvir too, but you said it's less common now.
Exactly. Daclotasvir, DCV, is another NS5A inhibitor. It binds to NS5A, hindering replication and assembly. Similar to Letipasvir, pre-existing resistance mutations, like Y93H, can be an issue and can persist. Daclotasvir comes as a separate tablet, usually 60 milligrams once daily, taken with sofosbuvir. An important difference is that daclotasvir is metabolized by the CYP3A enzyme system.
Meaning more drug interactions.
Potentially, yes. Its dose might need adjusting if taken with strong CYP3A inhibitors or moderate inducers. Potent inducers are contraindicated. While it's FDA approved with sofosbuvir for genotypes 1 and 3 and for HIV co-infection, the reality is it's rarely used in the US now.
Why is that?
Mainly because other highly effective co-formulated pan-genotypic and often cheaper options have become available. Why use 2 pills when one might do and cover more genotypes? When used, SVR rates are good, though maybe a bit lower in cirrhosis where ribavirin might be added. Again, generally well-tolerated, headache and fatigue are common.
Okay, so daclotasvir exists, but largely superseded by newer combo pills. Now, velpatasvir, this is in the common pan-genotypic combo with sofosbuvir, right? SOVL. This sounds like a big deal.
It really was a major step forward. Velpatasvir, a VEL, is another potent NS5A inhibitor. It's available in that fixed-dose combination with sofosbuvir, SOFVL. And its huge advantage is its pan-genotypic activity. It works against all 6 major HCV genotypes, 1 through 6.
That simplifies things massively.
Immensely. Genotype testing isn't always needed before starting therapy with SOFVL. Generally, baseline resistance mutations don't significantly impact its effectiveness, except potentially for one specific RAS, Y93H, in cirrhotic patients with genotype 3. That's a niche case requiring attention. Like LDVSOF, it's taken once daily and its absorption is also pH dependent, so the same precautions apply regarding acid-reducing medications. Take antacids separately, limit H2 blocker PPI doses, and specific timing instructions apply if using PPIs.
Cure rates.
Excellent. Often 99% across most genotypes after 12 weeks, maybe slightly lower, around 95% for genotype 3. It's also a key option for decompensated patients, often with ribavirin added. Side effects, usually just headache and fatigue. Velpatasvir does have a few more potential CYP3A interactions than Letipasvir, so potent inducers like rifampin or efavirenz must be avoided. It's also approved down to age 3 now.
Incredible. Pan-genotypic, high cure rates, short duration. SOFVL sounds like a workhorse. Now, what if someone fails a DAA regimen? You mentioned voxeloprevir as a salvage option.
Correct. Sometimes, unfortunately, initial DAA therapy doesn't lead to SVR. For those situations, we have voxeloprevir, VOX. It's an NS3 protease inhibitor packaged in a 3-drug fixed-dose combination with sofosbuvir and velpatasvir, SOF-VOX. Its specific role is as second-line treatment for patients who previously failed a DAA regimen, particularly one containing an NS5A inhibitor.
Does prior resistance matter for this combo?
Generally, no. That's the key advantage for salvage. The presence of common NS3, NS5A, or even NS5B RS before starting SOFVOVX usually does not affect the likelihood of cure with this powerful triple combination. SVR rates are very high, around 96%, even after prior DAA failure. It's typically given for 12 weeks. One important point, its absorption is significantly increased by food, especially fatty food, so it must be taken with a meal.
Any major limitations?
Yes, a critical one. Voxeloprevir exposures are significantly increased in patients with moderate to severe hepatic impairment. This raises concerns about potential liver toxicity. Therefore, SOF-VLVOX is contraindicated in patients with decompensated cirrhosis, Child-Pugh B or C. That's a class effect for HCV protease inhibitors. Side effects can include headache, fatigue, diarrhea, nausea, and it has a complex drug interaction profile, so careful review of other medications is essential. Potent OATP inhibitors like cyclosporine are contraindicated.
Okay, so SOFVLVOX, powerful salvage therapy, overcomes most resistance, take with food, but contraindicated in decompensated cirrhosis. Now another major combination, glycopivir-pibrentasvir. GLEP. This one seems unique too, especially for its short duration and use in kidney disease.
Yes, glycoprevir, GLE, is an NS3 protease inhibitor, and pibrentasvir, PIB, is an NS5A inhibitor. They come together in a fixed-dose combination, GLE-PIB. This regimen has several standout features, like SOFEL, it's pangenotypic. But its real claim to fame is the potential for an even shorter treatment duration. Just 8 weeks for most treatment-naive patients, including those with compensated cirrhosis, achieving SVR rates of 95% or more.
8 weeks. That's amazing.
It really is. It simplifies things even further. Another major advantage is its utility in renal impairment. While drug levels are a bit higher in severe kidney disease or dialysis, GLE-PIB has been shown to be safe and highly effective, SVR at 97%. It's become a treatment of choice for patients with significant kidney disease.
So pangenotypic, 8 weeks for many, good in kidney disease. Any downsides?
Like other NS3 protease inhibitors, it's contraindicated in decompensated cirrhosis, Child-Pugh B or C, due to increased drug levels and potential liver toxicity. It's taken as 3 pills once daily and should be taken with food to maximize absorption. Side effects are typically mild: headache, fatigue, nausea. Drug interactions are a consideration. Potent inducers like rifampin or certain anti-epileptics must be avoided. And like some other DAAs, there's a warning against using it with ethinyl estradiol-containing contraceptives due to risk of liver enzyme elevations. Also avoid HIV protease inhibitors and cyclosporine. It's also approved for children down to age 3 with special pellet formulations for younger kids.
Incredible. GLE-PIB. Pangenotypic, often just 8 weeks, great for kidney disease. Take with food, but avoid decompensated cirrhosis and watch certain drug interactions. One last combo. Grazoprevir, GZR-RUBR, what's its place?
Grazoprevir, GZR, is an NS3 protease inhibitor, and elbasvir, EBR, is an NS5A inhibitor. They come in a fixed-dose combo, GZR-RUBR. Its niche is primarily for HCV genotypes 1 and 4. Like GLE-PIB, it's also a good option for patients with renal impairment, including those on dialysis, showing good safety and efficacy.
Okay, G1 and G4, good in kidney disease. What about resistance?
This is where it gets a bit more complex. Pre-existing NS3RAs don't seem to affect its performance. However, pre-existing NS5ARS do significantly reduce SVR rates, particularly in genotype 1A patients.
So you need to test for resistance.
Yes, for genotype 1A patients, NS5A resistance testing is recommended before starting GZR-EDR. If certain RAS are present, the strategy is usually to add ribavirin and extend the treatment duration to 16 weeks, which significantly boosts the cure rates in those cases. It's taken once daily without regard to meals. Side effects are usually mild headache, fatigue, nausea. But like other protease inhibitors, it's contraindicated in moderate to severe hepatic impairment, Child-Pugh BC. And again, watch out for drug interactions, particularly with potent enzyme inducers, OATP inhibitors like HIV protease inhibitors and efavirenz.
Okay, GZR-EBR for G1, G4, good in renal impairment, but requires NS5A resistance testing for G1A, and it's contraindicated in advanced liver disease.
Wow. If we just sort of connect all this back to the bigger picture, what an incredible journey we've covered today. We've gone from the basic biology of these different hepatitis viruses, their impact on the liver, the methods for staging disease, all the way to these truly cutting-edge therapies.
From that persistent, frustrating challenge of HBV cccDNA making a cure so hard, to the absolutely groundbreaking, near-universal curability of HCV with these DAAs. It's just a stunning testament to scientific progress, isn't it?
It really is. And it raises an important point, I think. To truly master this material, like you said at the start, it's not just about memorizing drug names or cure rates.
Right.
It's about appreciating the nuances, how these drugs interact with the virus, with the patient's body, with each other, understanding why resistance happens, how liver impairment changes things, the details of pharmacokinetics, how food or stomach acid affects absorption, how transporters move drugs around. That's the level needed for true understanding, for that elite professional grasp. What stands out to you after going through all this detail, how these viruses really push the boundaries of medicine?
This deep dive has been incredibly comprehensive. We've hit the mechanics of infection, the precision needed in diagnosis, and the absolute transformative impact of this targeted pharmacology. Thank you for joining us on this journey to becoming truly well-informed on viral hepatitis. And maybe a final thought for you, the listener, to consider. With the astonishing success in curing HCV and the ongoing innovations trying to tackle HBV cccDNA, what really is the next frontier here? Will we finally crack the code to eliminate HBV cccDNA for good? Or perhaps will the focus shift even more toward prevention, developing broader vaccines to stop these infections before they even start, reshaping public health entirely? Until next time, keep digging deeper.